Representative CO2 waveforms are a critical component in the clinical application of capnography. Your understanding of the basic principles of capnography and of normal pulmonary physiology will help you to interpret these waveforms properly, leading to effective and timely interventions and successful clinical outcomes. Understanding the anatomy of the pulmonary system will help you to understand the measurement of CO2 over the respiration cycle. End-tidal CO2, or ET-CO2, is the non-invasive measurement of peak CO2 at the end of the tidal expiration. This is what capnography measures. Pulmonary anatomy can be broken down into three main parts: the upper airway, the tracheobronchial tree, and the lower airway. The upper airway consists of the nose, oral cavity, pharynx, and larynx. The nose is lined with a ciliated mucosa that warms and humidifies inspired air and removes foreign particles before they can reach the lungs. No gas exchange between air and blood takes place in the upper airway. The upper airway and the tracheobronchial tree is often called the conducting zone. The tracheobronchial tree is comprised of branching airways. The trachea connects the larynx to the left and right mainstem bronchi. The mainstem bronchi branch into lobar, segmental, and subsegmental bronchi before finally branching into the terminal respiratory bronchioles. No gas exchange takes place through this portion of the tracheobronchial tree. Because no gas exchange occurs in the conducting zone, the volume of gas in this zone is termed anatomical dead space. Past the level of the terminal respiratory bronchioles, the airway branches further into alveolar ducts and alveoli. This is the lower airway where gas exchange between blood and respiratory gases takes place. This is done through a process called diffusion, where O2 and CO2 move between the alveolus and the blood. For this reason, it is sometimes referred to as the respiratory zone. Ventilation is the inspiration and expiration of respiratory gases, sometimes referred to as external respiration. Exchange of oxygen and carbon dioxide occurs in the respiratory zone. Pulse oximetry is a non-invasive method of monitoring oxygenation. However, while pulse oximetry does measure O2 saturation in the blood, it does not provide information on ventilation status. Capnography provides a patient's ventilatory status by monitoring end-tidal CO2, which may lead to quicker identification of respiratory compromise than measuring SpO2 alone. Additionally, supplemental oxygen can often mask symptoms of respiratory compromise if capnography is not measured. If you were to measure your own pulse oximetry and capnography while holding your breath, you would notice that the CO2 waveform will immediately alert you that there is an absence of CO2. However, because there is still oxygen in the blood, pulse oximetry will continue to show normal oxygen saturation values for some time. Under normal healthy conditions, one pass of blood through the alveolar capillaries allows the partial pressure of CO2 in the alveolar air to nearly match the PaCO2 as measured by arterial blood gases. Although truly a different measurement, capnography measures the partial pressure of CO2 of exhaled gas versus an arterial blood gas sample. With capnography, monitoring is faster, continuous, and non-invasive, which may alert the clinician sooner to abnormal ventilation than a blood gas draw. The number of breaths we take in 1 minute is termed respiratory rate, or RR. The amount of air we breathe in one breath is called the tidal volume, or VT. If we multiply our respiratory rate by our tidal volume, we get a value called minute ventilation, or VE. A portion of the tidal volume does not participate in gas exchange in the blood because of the dead space in the conducting zone. This value is called dead space volume, or VD. In order to calculate the amount of gas that actually makes it to the alveoli, known as alveolar volume, we must subtract the dead space volume from the tidal volume. So, the alveolar volume, or VA, is equal to the tidal volume minus the dead space volume times the respiratory rate. The alveolar volume, compared to perfusion, the amount of cardiac output that reaches the lungs, is a ratio that is indicative of the quantitative matching of ventilation, V, and perfusion, Q. It is referred to as the VQ ratio. In normal, healthy lungs, there is a good match of alveolar ventilation and perfusion, resulting in an EtCO2 that closely matches the PaCO2. In healthy patients with normal VQ ratios, the gradient is 2 mm to 5 mm mercury. Two situations in particular can cause the VQ ratio to become mismatched: alveolar dead space and pulmonary shunt perfusion. Any part of the respiratory system that doesn't take part in the gas exchange is called dead space. Anatomical dead space in the upper airway is normal and is rarely changed by pathophysiology. However, dead space in the alveoli, where gas exchange normally takes place, may be an indication of pathophysiology such as pulmonary embolism or decreased cardiac output. Shunt perfusion can be thought of as the opposite of dead space. Shunt perfusion occurs when areas of the lungs are perfused but not ventilated. This can occur in conditions that cause the alveoli to collapse or fill with fluid, such as when there are increased bronchial and alveolar secretions that cause mucus plugging or atelectasis.